All right, ladies and gentlemen, we're going to go ahead with our next speaker, which is Dr. Mark O'Donnell. Dr. O'Donnell received his undergraduate degree from Washington Jefferson in Washington, PA. He is a fellow of the American College of Foot and Ankle Orthopedics and Medicine, the American College of Foot Surgeons, and the American Board of Pediatric Orthopedics. Dr. O'Donnell has been a member of the medical staff and in practice for 25 years, is a presenter at national meetings within the field of podiatry. As you know from coming to the classes or reading any of the information that's out on our vendor tables, foot injuries and foot problems and prevention of those problems is one of the very key things that we need to do for ourselves being diabetic. So with that, Dr. O'Donnell, thank you.
Thank you. Well, thank you everybody for coming out today. It's always a pleasure to present this to the community regarding the proper care of their feet and just some tips on diabetes in general. And some of this I'm going to go over today will probably be second nature to a lot of you. To other people, it'll be very useful and new information. Diabetes, as everybody knows, there's basically two types of diabetes that we're familiar with, type 1 and type 2. Type 1 being the juvenile diabetes and type 2 being the adult onset, which is becoming almost epidemic in the United States. Gestational diabetes also is a little bit not as prevalent as the type 2, but you see that obviously in heavier women during pregnancy, they will develop that, and a lot of times that will precipitate onto a type 2 diabetic. And naturally, the other causes could be secondary to chemical exposure, medications, obviously steroids. Any of you that have taken any steroids will know that you've had a bump in your sugars. And that can, long-term steroid use can lead to diabetes as well. Genetics obviously plays a role in diabetes. A lot of patients have family members that have been diabetic, so then they will develop that later in life, and it will either be due to the impaired insulin secretion or the insulin resistance. And the type 2 diabetes, basically you're checking that with the impaired fasting glucose or impaired glucose tolerance testing. Now, I was always taught that there was no such thing as pre-diabetics. It's like being a little bit pregnant. You're either diabetic or you're not. Well, now the ADA has changed their criteria, and there is a category for pre-diabetes. And basically, the parameters, the levels for fasting plasma glucose should be around 100 or less. Now, when I was in school, it was 120 or less. Now, it almost seems like they're getting back to those parameters with the pre-diabetic designation. So if you're over 100 or over 120 with your fasting blood sugars, this says 126, you're pretty much considered diabetic. And they're also using now the hemoglobin A1C as an indicator as well, which really and truly I think should be the gold standard, because that's what's measuring your sugars over the past 90 days. This is an interesting slide because I often see patients that come in with complaints of numbness or sores that don't heal on their foot, and they'll say they're not diabetic. And then when you go to examine the foot or you go to take care of the problem, they have absolutely no feeling, but they insist they're not diabetic. Diabetic patients have more than likely been diabetic for 5 years to 10 years before they've been formally diagnosed. So it's very important to keep up with your yearly physicals and pay attention to any of your symptoms and relay that to your primary care physicians. The incidence of the vascular changes will increase with time. As your disease state progresses, you will start to see a decrease in the circulation because the diabetic patients will tend to have more calcification of the arteries faster than a non-diabetic. So because of that, that's why you're seeing the vascular changes and the subsequent foot problems and sores and ulcers. And this is a kind of an astounding slide more so because of the incidence of diabetes in the younger population. They're starting to diagnose it now in children, which I'll get to down the road here, but 18.2 million people diagnosed with diabetes. 13.5 million are diagnosed, 5.2 million are not diagnosed yet. And as you can see, the bulk of those people are between 20 and 60 years of age. And again, the prevalence, obviously type 2 diabetes is the biggest player in this slide. Again, you have the 6.2 million people that have not been diagnosed, and you have 90 to 95% of all diabetics being type 2. And again, 41 million people being in that category of pre-diabetic. And this is a pretty current fact sheet that there are 23 million children and adults, 7.8% of our current population have been diagnosed with diabetes. There are still, again, 5.7 million that have not been diagnosed, and they estimate that 57 million people have pre-diabetes. And there are new cases, 1.6 million every year, again, in ages 20 and up. That's a pretty astounding factor. And again, I'm sure this is all going to come back. They're going to do their studies and find that it's, in addition to genetics, it's going to be a lot of the diet and the fact that there's non-exercise. Diet's the biggest thing. You'll see down the slides here, the kids that are, we have a problem with morbidly obese children because they don't want to play, they don't want to go out and run around, and they're eating McDonald's and Burger King and high-fat foods that are not good for them. Again, this is just restating what was on the other slide. Men, 13 million, women, 12.6 million, breakdown on the diabetes. 65 years and older, 29% of all the people in that age group have increased blood sugars. Ethnicity also plays a large part, again, in fact, due to the fact of the genetics. American Indians and Alaskan Natives they're the highest population of diabetics, followed by the non-Hispanic blacks and the Hispanics. Hispanics have typically very high blood sugars. And it could be demographics. Maybe they're not getting the best care. But it's a high, that and the non-Hispanic blacks have a high incidence of diabetes. And again, the non-Hispanic white group is 7%, which is lowest, which more probably because they're, again, the demographics, and they're taking better care of themselves. This slide is interesting because it's estimated lifetime risk in patients born in 2000. So these kids are 11 years old right now. So if you look at the genetic and the breakdown of the ethnicity, 32% are going to be, 32% of the men will develop diabetes, and close to 40% of women. And these are 11-year-old children. So they are at a very high risk for developing this disease. And again, you're going to see that because of the lack of exercise and poor diet. Obviously, complications with diabetes, and everybody is well aware of this, the heart disease and stroke, high blood pressure, blindness, and kidney disease are probably two of the biggest things we see, especially my renal patients. It's very difficult. They have a very difficult time regulating their sugars, and they are at very high risk for amputation because they have very poor circulation peripherally and distally. And amputation. The amputation thing does not refer to just digits. This is more referring to severe amputations, below the knee or above the knee amputations. And fortunately, we don't see them as frequently as we did 20 to 25 years ago, and that's due to the fact that people are better controlled and they're following up with their primary care doctors, and we have good vascular techniques that preserve and revascularize lower extremities. And that is what's really keeping those statistics down. Leading cause of blindness, new diabetes in adults 20 to 74 years old. Between 2005 and 2008, 28% of people with diabetes age 40 and older developed retinopathy. So it's also imperative that if you become a newly diagnosed diabetic, that you also add your ophthalmologist to your list of physicians to see yearly, just to be sure you're not developing any of the complications associated with diabetic retinopathy. Again, kidney disease, leading cause of kidney failure, 44% of new cases in 2008. End-stage kidney failure, very, very common in patients that are especially not controlled and have severe diabetic changes. Those patients typically will also, you'll see they'll have their cardiac issues as well as their eye issues as well. Neuropathy. This is a tough one because it's a very common problem with diabetics, and it's a term that encompasses a lot of symptoms. You could have complete numbness. You could be hyperesthetic. You could have increased pain. You could have tingling, numbness. Patients will often say they feel like their socks are balled up in their shoe. They take their shoe off and the sock is perfect. It's just a very difficult group of symptoms, and they're much more difficult to treat. There are certainly medications and gels and lotions on the market, and you almost have to go through everything to try to get to the end stage where patients are getting some relief of their symptoms. Obviously, the neuropathy affects the stomach, in the fact that patients will develop what's called gastroparesis. Their stomach doesn't function. They can't move the food through. Erectile dysfunction, certainly, a lot of times that'll be the initial symptom, and patients will go to the doctor for that and discover that they are diabetic. So the last thing, severe forms of diabetic nerve disease are a contributing cause of lower extremity amputations, and that typically is because the patients in that category absolutely have no feeling. They don't know if they step on a tack, a nail. They oftentimes, even though they're wearing shoes, they could go outside, get a nail through the sole of the shoe, and walk around, and just till that is rubbing the bottom of the foot raw, they get an infection because of the circulatory embarrassment, where they're not getting the proper blood flow. They don't get the antigens, the antibodies to fight these infections. And you can't stress that enough. If you have lack of sensation, to be very, very careful. Inspect your feet daily. Look at your shoes. Make sure there's no knots inside the shoe or a seam where the shoes were stitched, because these can all lead to very devastating problems. In addition to heat, I had a patient that went on a long road trip, and it was an older vehicle. Her foot was up against the side where the transmission was. It was very hot, had no clue, was in the car for 8 hours, and developed a full thickness burn that was almost devastating. 2006, 65,000 non-traumatic lower limb amputations were performed. And again, this is not a digit or just a toe or a forefoot. This is lower leg, below the knee or above the knee. Diabetic foot ulcers. Probably the most common thing that we see. It's one of the most common complications in diabetic patients. They have a lifetime risk of 15 to 25% of developing that. Fortunately, through programs like this and awareness, that should be a lot lower. I think patients are more aware. They're looking at their feet, or having a family member also check their feet to make sure they're not getting just a red mark or a blister. These are things that people seem to blow off and think, it's only a blister, but those blisters can lead to just devastating outcomes. And I tell the patients, it's not you're not crying wolf. If you have a red spot or a blister, call your doctor and say, I'm diabetic and I want to make sure this is not going to blossom into something worse. Again, the peripheral neuropathy is a major contributing factor in the development of these ulcerations. Typically what will happen, it may start as a blister or a callus. The callus gets thicker because your body is trying to put down this waxy type skin to protect a bony prominence or an area of irritation. And then because of the neuropathy, you don't get that feedback that you're feeling the burning or the pressure, and you could stand in the same place for 5 hours. Well, a non-diabetic patient has the feedback that goes, my foot's burning, I'm going to move. They offload, they get the pressure away, and they don't develop anything. The diabetic will develop bleeding underneath that callus. Then the blood becomes just an agar dish, petri dish, to just grow these normal bacteria that's on your skin, and that's what happens, and that's how you develop these terrible foot infections and these terrible ulcerations. Every 30 seconds worldwide, a lower limb is lost to diabetes. This comes from the American Pediatric Medical Association information. I would like to think that is going to be a longer time frame than 30 seconds. But again, early detection is the key to preventing any of these lower extremity amputations, as well as having a good vascular exam. Types of exams, visual exams, again, just looking at your foot, have a family member look at your foot, redness, pressure areas, break in the skin. Sensory exam, everybody, at least yearly, should be checked with a little monofilament over the bottom of the feet to check for lack of protective sensation or loss of protective sensation. That's very important. It takes really not much time to do that. Typically in my patients, when I'm taking care of them, I usually do that yearly, but throughout the year when I'm treating them, I can kind of sense, and I ask them if they can feel me touching their feet or feeling the instrument when I'm doing any type of foot care, and usually they can feel that. High risk, again, loss of protective sensation. That's really, as you saw from the other slides, that is one of the leading causes of the lower extremity amputations. Absent pulses in your feet and around the back of your foot and the ankle. Very important to have that done usually once a year. Again, I tend to do that several times when I'm treating my patients, because that is something excuse me, that can be taken care of. With the vascular intervention now, with stenting, angioplasty, and possibly lower extremity bypass, 20 years ago they didn't do that. 20 years ago, if you had a wound on the bottom of the foot and you had a below the knee popliteal or femoral popliteal bypass, that's as far as they could go. Now they're going all the way down through the leg, even to the top of the foot with their bypasses and stents. So again, cold foot, purple foot, cramping with walking. If you're at the mall doing the silver sneakers and you can only walk, from one kiosk to the other, and you have to sit and rub your leg, that's a warning sign that you've got a blockage somewhere in the lower extremity. So that's very important to pay attention to that. Foot deformities, obviously hammer toes, bunions, deformed feet, very flat foot. You'll have more prevalence of an ulceration or a pressure point with any type of foot deformity. If you have what's called a Charcot foot and the foot collapses, you'll see that either on the outside or the inside on the bottom of the foot, where the joints have collapsed and the bones are very prominent. History of foot ulcers, obviously, you'd be high risk, so we want to get the ulcers healed and eventually get you into some type of an offloading device, a shoe with some type of an insole to take the pressure off the bottom of the foot. And obviously, at risk for amputation from prior amputations. Patients with none of the following are considered low risk, and certainly I have diabetics that have complete sensation, they have outstanding pulses, hair growth and skin temperature are normal on the foot, no foot deformity, and no history of any previous amputation. And again, inspect between your toes. Look between for breaks in the skin, fissures, dry cracked skin, any type of blisters or calluses. Do not use any of the over-the-counter preparations for calluses because they have an acid that, and it always happens, a patient will come in, had they been in just to have the deformity or the lesion taken care of, they'd been fine. We become very close friends when they start putting this stuff on over the counter with the acid, and they're in weekly because of they've created a bigger problem because the acid has taken all the good skin as well as the bad skin. And the other thing is I tell patients creams are okay to put between your toes, any of the antifungal creams. You do not want to put ointments in between like a Vaseline type base on these ointments because if you do have a crack in the skin, just the normal bacteria that's on your foot would be driven in, and that could lead to an infection. Signs of decreasing vascular supply, as I said earlier, lack of hair growth, cold, purple, shiny skin, skin becomes very thin. They are signs that your circulation is not very good. And again, skin temperature, too hot, too cold. And thick nails. I mean, it seems so simple, but thick toenails, I can't tell you how many times over the last 25 years I've seen patients come in with a thick toenail. They have neuropathy. It's sticking into the toe next to it. They've got a full-blown infection, and it's from a toenail. So it seems so simple, but check your nails. Foot care is very, very important in the diabetic. Again, look at your socks. Like I said earlier, you have neuropathy, you pick up a nail on a shoe, it's sticking up into your foot, you don't feel it. Take off your socks. Patients will often notice this first. They'll see blood or they'll see pus on the bottom of their on their socks. Then they look at their foot and go, wow, I got a big hole in my foot. Again, footwear, torn lining, a knot where they were sewing the shoe. Something that simple will just keep rubbing the skin and you don't feel it and you end up with an ulceration or a sore. Make sure your shoes fit properly. If you're going to buy new shoes, go at the end of the day. Everyone has time during the day to do things, but you should buy your shoes at the end of the day when you've been on your feet because your feet will swell. They will have, and as we age, also make sure the shoes fit properly because your feet will get longer and wider, just a normal aging process. So they are very important things to think about when you're going to buy shoes. And depending upon, there's several areas in the Pittsburgh region where you can, as a diabetic, as long as you are under the care of your primary care physician or your endocrinologist, under Medicare guidelines, you are eligible for extra depth diabetic shoes with 3 pairs of insoles that are padded. And I tell my patients that absolutely positively you should pursue that yearly. I have some patients that do it every other year. They may not be as ambulatory. The shoes are okay. But I think that is a very important thing to do, especially since you have the coverage and Medicare provides for that. Comprehensive foot exam. Again, we're looking at skin condition, breaks in the skin, dry skin, scaly skin, any calluses, any deformities, hammer toes, bunions, collapsed arches, checking your pulses, and your sensory exam. Now again, in the sensory exam, I check all the toes, ball of the foot, heel, and the top of the foot, and the side of the foot, because again, if you're just checking the bottom of the foot, several patients will have one toe that they can't feel anything. They may have several toes, but they may have complete loss of sensation over the outside of the foot or the inside of the foot. So it's very important to check that as well. Toes are the first area to lose sensation. So this is what I was talking about, the monofilament. It's like a 5.07 is the diameter of it's like a stiff fishing line. I usually test first on the back of the wrist because everybody can feel that. and then we check the toes. And it says 5 defined areas. And if you're looking at any of the textbooks, the defined areas are 2 toes and 3 areas on the ball of the foot. Well, I check all the toes because you have 5 toes, or you should. 3 times a year, high risk, I agree with that. Typically, we see our diabetics anywhere from 10 weeks to 3 months, similar to what the endocrinologist will be following you. So it's a good thing to, if you're high risk, you'll know that going in. Low risk patients, I certainly have diabetic patients I see once a year. They're fine with that. They have not developed any neuropathy yet. They have not developed any thick or mycotic toenails. So they could get by with once a year. Again, footwear assessment, make sure that the foot matches the shoe and vice versa. You don't want to try to put a size 8 foot into a size 6 shoe. Also, check your shoes. This is always something that amazes me. I had a diabetic patient who, believe it or not, he delivers for a pharmacy, and he came into the office with just a screaming infection. He had a pill bottle in the end of his shoe. Don't ask me how it got in there, but just put your hand in your shoe before you put them on, just to make sure that if you have any grandchildren or children, they're not throwing stuff in there and you jam your foot in there, and next thing you know, you're dealing with a problem. Again, the diabetic treatment team, the vascular, we work very closely with the vascular surgeons. Fortunately, at Passivant Hospital, we have a great group of vascular guys and gals who are very well trained in intervention in the lower extremity. And they know that I'm not crying wolf. When I call their office and say I'm sending someone up, they fit them in because they know it's usually a problem. But even in a patient that has a non-healing wound for a long period of time, we like to have them at least get a baseline or be seen by the vascular guys, because they're going to be your friend in the long run. This is just an example of a chronic wound. As you can see, this patient fits the risk factors as earlier. Prior amputation, the 5th toe is gone. He's got a callus up in the area right here underneath the 4th metatarsal head. And this is, again, the type of ulcer like I was talking about on the bottom, on the outside of the foot where the foot is collapsed. And these are very, very common, very treatable, but it takes a long time to heal them. Again, type 2 diabetes in youth. It's very alarming that this is starting to be seen in our population. Again, the ethnicity here, Hispanic or Mexican descent. Again, look at the diet they're eating. These kids probably, eat this type of food all the time. They're not being well taken care of, and this is part of the reason the childhood obesity and the diet again it's very alarming. And this is an interesting slide because this is. I got this slide from a friend of mine. I was at a conference in the beginning of the month out in Montana, and he gave the presentation. And I asked him for these slides because I knew I was going to be here. And this is kind of again, a disturbing bit of information. It used to be that adults only had type 2 diabetes, and it was usually, again, you saw it in the 60-year-old age group and older. You didn't really see it in the 30 and 40 and 50-year-old age group. Now you're seeing it in people under 20. And 3,700 people under 20 are diagnosed annually, and it's really 3,700 in a big country like we have doesn't seem like a lot, but it's alarming, because then it reverts back to the slide where people born in the year 2000, the prevalence of developing diabetes. Again, rates of new cases among youth under 20 years by race and ethnicity. All races, 20%, per 100,000 per year. And again, type 1, type 2, it's mostly type 2. And, you look at the American Indian and the Asian Pacific, they're that ethnic group is very high for developing type 2 diabetes. Again, risk factors, overweight, obesity, BMI greater than 85th percentile. You know, the big thing is the belly fat. You know, I'm probably right there knocking on the door for developing type 2 diabetes, but it's a fact. I mean, everybody is overweight, and we really have to pay attention to that in our fat intake and our diets, because it's really it's becoming really an epidemic. Again, the genetics, family history, and sex. Girls more than boys developing in youth for developing the diabetes. Screening guidelines. You know, check the height and weight of the children. They should be, you know, greater than 120% of their ideal health and weight. And they're screening these kids now at age 10 or at the onset of puberty. You know, and again, this isn't all children. It's the high risk children, overweight, family history. They're the patients that are being tested. Management, again, long-term glycemic control. A1Cs less than 7%. You know, if you can keep it between, you know, normal and 6 is great. Under 7, you keep it there. These people, not just youth, but adults as well, you'll have a better chance of not developing a lot of the complications. Lifestyle changes, again, diet and exercise. You know, get the PlayStations away from the kids. Don't take them to McDonald's. Get them up and participating, you know, in outdoor activities. Again, family involvement, diet, exercise. There was a thing on the NFL had a big push about a year ago, and I think they call it 60 for 60. They have kids exercising 60 minutes a day, and you know, for 60 days, and it's just to get them up and active. It really had nothing to do with type 2 diabetes, but they were pushing that because of the epidemic of childhood obesity. And it's a real problem. The funny thing about it is, you look at the childhood obesity and you preach about diet, and I look at some of the things on my kids' menus at school, and it's like, you know, what are they doing? They have like junk on the menu, so the kids, at least my kids, aren't getting pizza every day, or you know, some of the things that are just not really healthy for them. And you know that, you know, even McDonald's now has a healthy diet. They're putting on more salads, more fruits, yogurts, and they're giving people more choices. So I'm not bashing McDonald's or Burger King or Arby's or any of the fast food places, because they all know they're under fire, and they've changed their menus so people can make a good choice. Any questions? I'll be happy to take them. Thank you. Yes. I would absolutely get the bathing shoes, and I'll tell you why. Even the patients that go in the pool that do water aerobics, and they're in 4 to 5 feet of water, and even though they're bouncing in the water and there's less strain on your joints, those feet are rubbing against the bottom of the pool, and typically the bottom of the pool is abrasive because they have some type of a sand in there so you don't slip naturally. And if you have any type of neuropathy, you're just going to beat the heck out of the bottom of the feet. So definitely you can get Dixasm for $12. They're cheap.
Should the calluses be shaved or not?
They should be. If you have neuropathy and you're getting some large callus buildup, and obviously you can't feel that, or if someone's looking at your foot and you can see the pinpoint bleeding under there, they should be. And then that's also when you should also be getting the insoles, the plastizote, or the insoles for the shoe to try to help offload that. So they should be, absolutely. Not soft shoes, but the insole in the shoe, the diabetic plastizote insoles. Probably the worst type of shoe you could wear is like a pair of Keds or the old canvas Converse, because there's no support whatsoever. I mean, if you're putting them on to go out to get the mail, that's great, but that's about as far as it goes. A good shoe would be like a good running shoe. It's going to have a nice stiff heel. You're going to have some arch support. They're typically lightweight. They're wide in the forefoot. Make sure you get a shoe that does come in widths. New Balance does make a shoe that comes in widths. But in reference to your leather, SAS, any of the high-end shoes will have typically a nice soft leather on the outside and a lining inside that is, free of any defect or any stitching. That's the key thing. You want to put it in, make sure there's no seams on the inside around the toe box. The other thing, if anybody wears steel-toed shoes, check them, because oftentimes the liner in the shoe will wear out, and then you have that piece of steel in there that's jamming into the feet, and I've seen complications with that as well. So it's very important to check the inside of the shoes. The structure of the shoe, all the good shoe manufacturers pretty much will understand that these patients are going to be taking out the footbed, and the footbeds aren't glued down. So when you're going to look at a shoe, take the footbed out. If it's glued in, go find a shoe where you can easily remove the footbed, because you're going to want to put your own footbed in there, whether it's custom or a Plastizote. Plastizote is it's like a very lightweight, like styrofoam, but softer, if that makes sense. It's spongy. It doesn't really have a memory, but it lasts usually for, depending on how ambulatory you are, 4 to 5 months. With the diabetic shoes, they'll give you 3 pairs of Plastizote insoles, and you should change them or rotate them every 4 months. I have patients that don't do that, and they put them in a drawer and they use them in other shoes, which is fine depending on how ambulatory you are. But they will wear out. But Plastizote is a material that is, it's moldable to your foot. It can either be heat molded to your foot, or just your natural shape it'll adapt to your foot.
We have a question over here, Dr. O'Donnell.
Yes.
Yes. What's the percentage of the diabetes to have neuropathies later if they don't have it now?
If they don't have it now, could they develop it? It's certainly possible. Again, a lot of the times and I don't know the data on that, but I know that glycemic control is very important, because I have patients that have neuropathy, terrible burning, just different symptoms, and once their sugars get under control, their symptoms will somewhat subside. I can't tell you any data that says if you are a diabetic right now and you don't have any neuropathy, will you develop it? As long as your glycemic control is within the parameters in the good range, you have less of a chance of developing neuropathy.
I was walking 5 miles a day, and I was wearing leather New Balance sneakers, and I was getting blisters. Now, someone told me I should use mesh. Do you know anything about that would bring
mesh?
that? Yeah. In other words,
that's what I'm wearing.
Yeah, they said the leather for walking.
It's very light, and it will, give a little bit better than a leather or like a Naugahyde type material.
So I should probably switch.
Again, look at your shoe, make sure you have the right size. More importantly, make sure that your foot is measured.
No, it was fine, but
and you have the right size.
5 miles, I was starting to get slight blisters, because that was a lot of walking. So, okay, I'll switch to another kind of sneaker.
Yes, sir.
Thank you. Dr. O'Donnell, I have peripheral neuropathy, and I was taking Metanx, which is advertised as possibly reversing nerve damage and increasing the blood flow. It didn't seem to work when I took it for about a year. I just wonder if there's any other product on the market for peripheral neuropathy.
Well, that product is what they call a nutraceutical. It's not a pharmaceutical. The data on that is, I've looked at that, and there's a fellow that speaks around the country on it and thinks it's the greatest thing since sliced bread. I agree with you. I have not seen patients that have used it get much of a relief from it. The current medications that we use that are FDA approved for neuropathy, obviously the Cymbalta, that is one of the medications that's been out, and again it's hit or miss. You've got to try it. Gabapentin, the Neurontin, when it first came out, that was going to be the savior for neuropathy. Unfortunately, with gabapentin, you've got to take a boatload of it, and by boatload I mean upwards of 3,000 to 3,600 milligrams a day. So the patients that come in that are taking 100 or 300, you're kind of wasting your time. You might as well, take an Advil. You really have to titer that gabapentin. All the medications that have been FDA approved, it's just like an antihypertensive. What may work in you won't work in the person next to you. So you got to kind of go through the whole regimen of them and see. And it gets very frustrating. And at the end of the day, maybe nothing will help. Maybe you can use a topical. There's a great lotion called Sarna, S-A-R-N-A, that is used for itching, poison ivy, poison oak. But it's very soothing, and a lot of patients will use that for neuropathy. I've used Zoloft in the past, an antidepressant. All these drugs are based on that same chemical formula and pathway. Zoloft, it's generic, so it's inexpensive. Might even be one of the free drugs at Giant Eagle, I'm not sure. But it's again, it's worth trying. It's one of those type of things. And my favorite drug, which they pulled off the market after 55 years, don't ask me how they discovered now it was bad, was Darvocet. Darvocet was a pain medication, narcotic, but a Darvocet at bedtime, I'll tell you what, patients were very happy campers with that. And they pulled it off the market. They said they discovered, I guess no one had a heart attack 50 years ago. I don't know what the deal was there. It just seems awful shaky to me, but it was a great drug. Yeah, right. They weren't making enough money. You're right.
We have another question here.
Yeah. Doctor, is capsaicin effective? And would you mind quickly listing those drugs again, because I wasn't able to write them all down?
Sure. The capsaicin, interesting story about that. I had a patient that years ago brought a tube into my office, and I think they bought it in Canada. It was before it was available here. And capsaicin is derived from peppers. And it was supposed to knock out the delta fibers and the nerve endings, so you didn't have these, burning and the problems with the symptoms of neuropathy. So I got all excited. I'm thinking, this is great. This is going to be my saving grace. I get a tube of capsaicin and everyone's going to be cured. Well, I couldn't find it. I was, CSI on this. I couldn't find it anywhere. Well, then about a year goes by and now it's, over the counter and everybody has it. Again, it's one of those things that it's individual. It's certainly not going to hurt you. The worst thing it's going to do, you have to wash your hands like crazy. You can't touch your eyes or touch your nose because you're going to burn. It's just like chopping a jalapeno. But the capsaicin, there's certainly a place for it. The other drugs were gabapentin, Neurontin, Neurontin, Zoloft, Cymbalta, and Lyrica. I forgot to mention Lyrica. Lyrica is another one. The problem with Lyrica was a lot of patients developed ankle swelling, and they really weren't happy about that. But Lyrica was a Lyrica, was a FDA approved for diabetic neuropathy. I think it may have come out after Cymbalta, but it's an effective drug as well. So. All righty.
Yes, doctor, would you comment on gel shoe inserts?
That's I'm in the wrong business. I should have gotten into this foot business selling crap because it's $1 billion industry, and I wouldn't be driving a Nissan. There's so much stuff out there, and again, it's not going to hurt you, but it's not effective. It's not going to give you any support. It's not going to really offload your areas. Dr. Scholl's does a great job marketing their products, and I guess out of the box, the gel sole is probably going to feel good. Everyone's gelling; they feel good, but I think you're not going to have any longevity. So you're kind of throwing good money after bad, just like tennis shoes or running shoes. I tell patients, if you're wearing them every day and you're a runner, you're supposed to change them every 6 months. If you're wearing them, a couple times a week and you're walking at the mall, they're going to be good for a year to 18 months. So, you're going to get what you pay for in any of these products. So I just warn patients, you get the the glossy ads in the Sunday paper, or who's the Lillian Vernon catalogs. I get patients come in with all this stuff. What about these and all these splints? I mean, truly save your money. Save your money.
Another question here.
Yes, I don't think this is a diabetic question, but there may be a relationship. I sometimes wake up in the morning with leg cramps, you know, in the calves and the thighs. I presume that's a muscular thing. It has nothing to do with diabetes.
You're right. It's mostly muscular. Certainly cramping in the calves with walking any distance that's reproducible would be a cause to have a vascular exam. But the cramping, in the muscle cramping, it could be your electrolytes are out of whack. You're just not, or just the muscles cramp. People have restless leg syndrome, which no one knows why that occurs. My father has it. He yells at me all the time, "Why can't you help me? Why can't you fix it?" It's like, Dad, it doesn't work that way. So it's more than likely not a symptom of diabetes.
Doctor, I go to the gym about 5 days a week, and periodically I'll end up with like athlete's foot. And I've noticed with a spray that there's probably alcohol in it, and it kind of like dries up my skin, so I'm assuming that I should use a cream as opposed to a spray, or what's your recommendation?
The Tenactin spray, I'm not sure the alcohol content in that. I tell patients to get the Equate because it's the exact same thing, and it's like $2 a can versus $8. Creams, certainly clotrimazole cream is over the counter. That's a good antifungal. That would be fine. And if you really get bad athlete's foot, you can take a medicine for 2 weeks and it'll cure the skin right away. I mean, it's a oral Lamisil. It's safe. It's an antifungal basically for toenails, but we use it for skin as well. So typically you're using that for 2 weeks to a month for severe, tinea or athlete's foot infections. So yeah, the clotrimazole cream over the counter will be fine.
Another question here.
At Walmart, there is a machine that you stand on to decide which orthotic to buy. They're $50 or something like that. Is there any good to this?
I've seen the ads. I haven't gone in to actually stand on the machine to see what they're going to tell me. I haven't even seen the device, to be very honest with you. There are a lot of good over-the-counter devices that you can buy that are less expensive than that. New Balance makes one that is orthotic with a top cover. You can get them online. A patient told me that there's a place called Cobbler's Corner in Ohio, over near Youngstown, that'll ship them to you for $2, and they're $34. I know that the New Balance store sells them for about $45.
eBay.
So, what's that?
I just bought a pair on eBay for $34.
There you go. They were very popular. I don't know if they're still popular. It was a very popular cult thing, I guess I could call it, several years ago. Nikken, N-I-K-K-E-N, was the company. They were very expensive. I don't know enough about it to criticize it. I just know that they were very expensive. And, at the end of the day, I guess if you're having that severe neuropathy that's not responding, you're going to grasp at straws and try anything. As far as I'm aware of, there was no adverse effects of the magnets. I had a patient that believed in all that magnet stuff, and he even kept his drinking glass with water on a magnet thing. He thought that was good for him. I don't know. I just never sat in on any of those lectures or bought into the whole magnet thing. But it was very successful. It was very popular for a number of years.